So I'd like to invite Dr. Rebecca SUMALINI to speak on CVI incidence, screening, diagnosis, and management.
Thank you for the invitation to be part of this session. So I'll be talking about, while we are still staying on the pediatric visual impairment and also talking about the rehabilitation aspects, we'll dive a little bit deeper and talk about not just ocular causes of visual impairment, but about the neurological causes as well. So as rightly mentioned, I'll be talking on CVI. I have no conflict of interest, although I'll be telling about few techniques and tools. And I'll start off with this powerful statement by someone who's revered in the field of CVI, Dr. Gordon Dutton. He goes on to say that when you met one child with CVI, you met one child with CVI. What does he mean by that? Just that the generalized, it's not easy to generalize the condition because of the varied presentations of children in this specific cohort. There are various definitions for CVI. The most commonly used ones are what I've highlighted here. It's a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairments. It's also a neurodevelopmental disorder characterized by deficits of visual function and functional vision, and that are caused by neurologic damage to visual pathways and processing areas in the brain. So both the definitions essentially are saying that CVI is beyond the ocular realm. Right? So the most common ocular conditions that are noted in children with CVI include the uncorrected refractive errors, squint, cataract, and optic atrophy. The reason why I've highlighted optic atrophy, because it's very commonly seen in children with CVI, both partial and full optic atrophy. This is because it's a retrograde transsynaptic degeneration that is seen in these children. So it's not just ending at the occipital lobe, the damage extends towards the parietal lobe and also towards the temporal lobe, and children with CVI can have difficulties with visual spatial awareness skills, with visual motor integration. A simple eye-hand coordination task can be very challenging for these children. Motion perception, even a basic task like recognition of shapes or sizes or faces can actually be very challenging. And even perceiving two or more things at a time, especially when the child has to spot the mother in a group of parents, the child may find it to be very difficult. Why are we talking about CVI? Because it's on the rise. It's the leading cause in developed countries, and it's rapidly increasing in developing nations as well. CVI often gets undiagnosed or underdiagnosed. This is clearly due to lack of awareness among key stakeholders, including clinicians like optometrists, ophthalmologists, rehabilitation professionals, neurologists, pediatricians, and so on. There's challenges in assessment, I'll come to that, and also inadequately trained clinicians. Additional developmental delays can add to the complexity of the condition because the focus shifts to the more obviously affected developmental milestones. Like, for example, a child is not able to walk or the child is having difficulty to talk. That can get more focus than the child having vision concerns. So the focus shifts to the more difficult concerns, and also medical issues like seizures. So if I have to give you a global picture of CVI, I'm afraid I do not have much data, as there's scanty literature out there across different countries. But I found these to be the most prominent studies. The first study from India, we had 33% of children who had major cause of profound visual impairment in less than 3 years of age. That was found to be in the southern part of India. And in another study in the southern part of India, we see that 70% of children had CVI. This was the most common cause in children studying in special schools, not special schools for the blind, in the other special schools. And we also have a study from UK which points out that 1 in 30 school-going children have at least one CVI-related vision concern. And from the US, from the various data, the Perkins International website mentions that over 180,000 children are estimated to have CVI in the US. And we have some data from the West African countries as well. 2 to 3 to 7% of children in the pediatric vision impairment group have CVI. And we also can take the data from Australia, as mentioned by Dr. James Elder, around 1.8%. And looking at the incidence, this is data only available from the US. You can see the data ends at 2003. There's no recent data after that. 36 per every 1 lakh children in late 1980s, which is now grown, not now actually, in 2003, which was 161 per every 1 lakh. What are the causes of CVI? The top 3 in the list are the actual most commonly seen causes. One is the hypoxic ischemic encephalopathy, periventricular leukomalacia, neonatal hypoglycemic brain injury. There could be genetic causes as well, metabolic disorders, and trauma. So this is a clear call for good antenatal and neonatal care, especially if we are to avoid the top causes of CVI. And how do we go about diagnosing CVI? It's not very easy. These are the three most important parameters that are used by pediatric neurologists and pediatric neuro-ophthalmologists that include the birth and the development history, visual behavior, and the visual concerns that is observed during the examination or as reported by the parents or primary caregivers, and more importantly, the neuroimaging findings. Birth history, we all know the conventional birth history. We also need to check about their neonatal complications like hypoglycemic insult, jaundice, meconium aspiration, respiratory distress, hypoxic insult. In one of the in-house papers by our team, we found that 50% of children with CVI had etiology of neonatal hypoglycemic brain injury. And all of the parents invariably reported that the child did have a hypoglycemic insult in the neonatal period. Also, it's important to dwell on the maternal health as well, like gestational diabetes, hypertension, any chronic illness during the pregnancy, or trauma, or any event of miscarriages. These are the important birth history that you would look at. In addition to birth history, we also need to concentrate on the developmental history, not just the visual developmental milestones. You have to concentrate on the other developmental milestones as well. So an easy to remember mnemonic would be 1 for walk, 2 for talk. If the child has not attained these milestones as past the age, so it should raise a red flag, and you need to refer the child to a developmental pediatrician for further assessment. Looking at the visual behavior, here are the 10 most commonly and unique characteristics that are observed in children with CVI, ranging from need for movement, there is specific visual field preference, there is visual latency, non-purposeful gaze, the child would just be looking towards a light, having a light gazing behavior, absence of visually guided reach, and so on. So while proposing these 10 unique characteristics, there's a way to assess that and actually understand what is the severity of CVI like. We also have Gordon-Dutton's CVI inventory scale. Here it is ranging from, for the age range of children from 4 to close to 12 years of age, this can be used. Simple questions are given here for your reference. These are all available on the Ulster University website. Does your child trip over toys and obstacles on the floor, trips at the edges of pavements going up or down, and simple questions like this, which can come in very handy when you're assessing the extent of CVI. Visual concerns, when we had carried out an in-house study, we found that children with CVI, the parents of children with CVI reported 14 unique visual concerns that are listed here, including difficulty in recognizing faces and maintaining eye contact being the top 2 causes. And a very interesting finding that had come out from the paper, when we had clubbed those children having recognition of faces and eye contact in group 1 and had the other group with other concerns, we found that both functional vision score and the contrast sensitivity score was actually significantly lower when compared to those who had other concerns. So this again clearly says that when children with CVI come to the clinic, it's very important to check for their eye contact, whether they are able to maintain eye contact, whether they are able to recognize faces. And if parents are not reporting by themselves, it's important for us to proactively look for it. Neuroimaging findings, studies clearly point out that visual cortex could be damaged, and particularly optic radiations, this could actually be an early predictor of CVI. And Sioni et al. In this paper goes on to mention the different grading that can be used to understand the location and the extent of CVI. So in order to diagnose CVI, not just the 3 parameters, there's a way forward to go much more deeper, like having a comprehensive vision assessment, visual perceptual assessment, clinical electrophysiology, and a neurodevelopmental assessment. How do we go about screening them? It's not easy in a busy clinic to run a 50-item questionnaire, right? So in order to screen for CVI, Gordon-Dutton proposes these 5 questions that can be used, and 3 out of 5 scoring that comes out positively on these screening questions, then you need to go ahead and comprehensively assess the child. So I'm just going to propose 4 important clinical pearls that you could remember while assessing and managing children with CVI. Pearl 1 would be children with CVI may have several functional vision challenges despite good visual functions. What do I mean by that? So let's have a look at this video. This particular child was an acquired case of CVI, had binocular visual acuity of 20 by 30, and you can find the difficulty that she has in this video. So a simple task like of matching shapes on the Leah 3D puzzle was very difficult for her, despite having a good visual acuity of 20 by 30. Now this happens in cases when there's higher order visual processing disorders. And we also see the same child had difficulty in recognizing facial expression. So my task that I gave it to her was just pick up the card which has a happy face. And the child was actually struggling with it despite having a 20 by 30 visual acuity. So this clearly shows that their children with CVI do have higher order visual processing dysfunction, and they need to be checked for those. Behavioral issues again are very common in children with CVI. You know, the child may not be wanting to look at your grading acuity tests or the letters that you put up. Even looking at the balls can be very challenging. So then how do you go about it? Assess using less cognitively demanding clinical tools. A 10-year-old child comes, do not assume that this child may be very familiar with letters and just put it on. Check for the child's familiarity, look for the interaction, what they have with you, and then if needed, come down the hierarchy and show easier tasks, like for example the grading acuity test or the matching acuity test. We also have an app called the Peekaboo Vision application.
Very good. Very good. You should wait now, okay?
So as you see in this app, it's quite interactive that way for the child to follow through the test, and very encouraging for the child to perform the test. In other than acuity, you would also like to concentrate on the contrast sensitivity and the visual field as well. Objective refraction and amplitude of accommodation cannot be ignored because this definitely needs to be addressed. We also have the SANET Vision Integrator, which is both used as a diagnostic and a therapeutic tool. Let's just play this video here.
Next, Karana.
So this particular tool, the SANET Vision Integrator, is used both for diagnostic and therapeutic purposes for understanding the child's eye-hand coordination, visual spatial awareness, attention, memory, and etc. So after we advise for the therapy, we can also monitor the progress of the therapy sessions using this device. And functional vision assessment definitely is the key. Even a simple task like asking the child to reach towards the ball and see how the child is reacting to it. And it's important to mention if there's any latency or the object characteristics, the contrast, distance, and the room illumination. So looking at third pearl, oftentimes simple assistive devices may provide a solution to the complex visual needs. We had a great talk by Sumit, who just mentioned about the different devices that are available. So telescopes, magnifiers cannot be ignored in these children as well, especially those who are having academic demands and are high functioning. And a simple material like a typoscope can actually declutter the reading material and help them focus only on what is to be read. And a magnification app like this is called the VZoom app, which is actually freely downloadable, that can be used even for your pediatric visual impairment group as well. And devices like alternate augmented communication for children who are pre-verbal or non-verbal. Coming to the last pearl, you may need to plan beyond a one-size-fits-all approach, especially when you're dealing with children with CVI. Customizing your rehabilitation plan is very important. Consider the child's visual functions, the functional vision developmental milestones, and it's always important to have the parents and the primary caregivers part of your counseling sessions, especially because rehabilitation management can be long-term, and in order for them to sustain and be on the same page, it's important to have all the primary caregivers as part of your counseling session. And in addition to what I've just mentioned, also it's important to co-manage these children because they may need occupational therapy, speech therapy, physiotherapy. So it's important to co-manage them with the rehabilitation therapist. So what are the key takeaways? CVI is a growing public health concern even in developing countries. Scanty literature as such exists on global stats on CVI. So definitely this calls for large and multi-centric epidemiological studies. Then the need for research focusing on evidence-based rehabilitation strategies and a clear need for interdisciplinary approach. So yeah, thank you.